Hello everyone and welcome to another general nephrology video. Today's topic is prevention and medical treatment of kidney stones. I'm Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. So there are several types of kidney stones. These are the most common. They are rare kidney stones that we're not going to talk about. So the most common are calcium oxalate, uric acid. Sometimes we see calcium phosphate stones. Cystine stones are not very common. And finally, we have struvite stones. Now, kidney stones, as you know, are very common. About 10% of the population have kidney stones, and the risk is higher in men, so about 11% in men, as opposed to 9% of women have kidney stones. Now, there aren't that many prospective clinical trials in nephrolithiasis or kidney stones. There are few. Hard endpoints include a recurrence of stones or increased dissolution, meaning dissolving of the stones. Changes of urine chemistry or supersaturation with salts is not a hard endpoint. Okay, now how do we prevent kidney stones? Now, everything we're going to say about prevention also applies to treatment, but let's talk about prevention. So, intuitively increase water intake. It has to be 2 to 3 liters a day, and it has to be spread throughout the day. Now, rarely there is a contraindication to drinking too much water, maybe someone with low sodium and so forth, but generally speaking, 2 to 3 liters a day is sufficient. Next, we have to limit dietary sodium intake to below 100 milliequivalents per day or 100 millimoles per day, which is the same as 2,300 milligrams per day. Why is that? If you have someone on a high sodium diet, that will increase calcium in the urine, and most stones have calcium. So high sodium means high calcium in the urine. On the other hand, low sodium means less calcium in the urine, and that's what we want. Why is that? If we lower dietary sodium intake, you are going to have more reabsorption of sodium in the proximal tubule. So sodium will be reabsorbed with water, and then calcium follows passively. So low sodium diet will lead to low calcium in the urine, and that's what we want. Now, we mentioned about high water intake, and this is a study from 1996, and it shows that if you increase water intake, the recurrence of kidney stones within 5 years is about 10%. Now, if you don't increase water intake, it's close to 30%. So this is a trial showing benefit of high water intake. Now, if you want to look at it differently, the interval of recurrence, okay, between a first stone and say a second stone, on high water intake, it will take longer, so 40 months. If you don't do anything, it will happen within, let's say, 25 months, in 2 years. So again, intuitively, high water intake is beneficial, and this is why we all do it. Now, next we need a diet that is high in fruits and vegetables. And why is that? Because when you do that, you have more alkali in your diet. So you have more citrate, and you want high citrate in the urine because citrate will prevent stones from forming. So the same way you want less calcium in the urine, you want more citrate in the urine because that will lead to prevention of stone formation, to dissolution of those salts. Another thing we need to do to prevention, and that might seem counterintuitive, we need to maintain adequate calcium intake from dairy products. So we do not want to limit calcium intake. Recommendation 800 to 1,000 milligrams. Now, having said that, you should not take calcium supplements. So calcium should come from dairy products. Okay, now why is that? Why do we not want to limit calcium intake, although most stones have calcium in them? because if you are on a low calcium diet, you are going to enhance the absorption of oxalate. So in the gut, in the bowel, calcium will bind oxalate. If you have low calcium, you are going to have more oxalate absorption and subsequently more calcium oxalate stones. So calcium intake has to be normal, but do not take calcium supplements. That actually might increase kidney stone incidence. Now, this is a study showing that if someone is on a low calcium, only 488 milligrams per day or less, you have more kidney stones as opposed, say, to a normal or a little bit higher calcium intake. You have less kidney stones, and you can see here the relationship: the less calcium, then the more kidney stones. Um, Same thing in men. Higher calcium intake is associated with less incidence of kidney stones as opposed to a lower calcium intake. Another thing we can do for prevention is reduction of animal protein intake. Why is that? If someone is taking high protein, you have, well, more sulfur containing amino acids, and that will increase the acidity, will increase the acid load because of generation of sulfuric acid. And if you have increased acid load, you are going to increase the excretion of both calcium and uric acid, and you are going to reduce citrate. So that's all bad. You don't want more calcium in the urine. You don't want more uric acid in the urine. And actually, you want more citrate in the urine. So you negate all three with a high protein intake. So you want normal protein intake, definitely not high protein intake. Especially, you want to reduce animal protein intake. Now, next thing we can do for prevention is limiting oxalate intake. So this applies to patients with calcium oxalate stones. If they have another type, then it won't matter. Here, a very important thing, vitamin C will be metabolized to oxalate. So especially people on high doses of vitamin D, and most of them are taking it for very dubious reasons, they should quit doing that. So what are foods that are high in oxalate? Well, you have rhubarb. Some people like rhubarb pies, beets, okra, spinach, yeah, sweet potatoes, all kind of nuts, tea, chocolate, black pepper, and soy products. I have to mention something. Some people drink so much iced tea, like 10 cups a day, and that can lead to so much calcium oxalate stones. So if you see someone with a lot of calcium oxalate stones, ask about iced tea. Now, next, we want to limit sucrose and fructose intake, and especially for young people, we want to ask about soft drinks. Okay, so non-diet, like regular soft drinks, have a lot of sugar, a lot of sucrose. So we want to investigate that because sucrose and fructose will increase stone formation. Sucrose actually increases urine calcium excretion, and that's not good. Okay, now we talked about prevention. What about medical treatment? Okay, now for people with calciuria, calciuria means high urine calcium, and high urine calcium means urine calcium above 250 milligrams on a 24-hour urine collection. We use thiazide diuretics. So thiazide diuretics, we use them, and in my mind, they're still indicated if you have high urine calcium. Otherwise, there's no point in using them. And at least in the United States, we use either chlorothalidone, hydrochlorothiazide, or indapamide. Many times we use amiloride or spironolactone or potassium supplementation to avoid hypokalemia, because if we use diuretics and we cause low potassium will lead to low citrate, and that's bad. So when you start someone with high urine calcium on a thiazide diuretic, you have really to monitor potassium. And if potassium is low, you have to either supplement it or you give something like amiloride or spironolactone. So pay attention to that. Now, if someone does not have high urine calcium, then there's no point in using a thiazide diuretic. Okay, now for people with low urine citrate, so we've done a 24-hour urine collection and urine citrate is low, this is also called hypocitraturia, we are going to use potassium citrate or potassium bicarbonate. And this is going to help because you have then more urinary citrate. And again, citrate prevents kidney stone formation. So again, this applies to people with low urine citrate. If urine citrate is not low, then there's no point in doing that either. What do alkali or citrate do? Well, they are going to inhibit crystallization of calcium oxalate and calcium phosphate. They are going to reduce the saturation, the supersaturation of urine of both calcium oxalate and calcium phosphate. And also they are going to prevent this heterogeneous nucleation when you have both urate, sodium urate, and calcium oxalate, when you have a combination of two type of stones. So basically, remember, citrate is good. The higher, the better. Now, alkali is going to raise urine pH, and that's going to be very helpful if you have uric acid stones, okay? You are not going to have uric acid stones unless the urine is acidic. If you make it alkali, you are not going to have uric acid stones. So that's why they're all also helpful in case of uric acid stones. Now, since we're on the topic of uric acid stones, which are very common in hot climate, sometimes you can even have big bladder stones from uric acid. First and foremost, you are going to increase water intake, like we said, 2 to 3 liters spread throughout the day, and you are going to do urine alkalinization with sodium bicarbonate, potassium citrate, potassium bicarbonate, and you are going to have the patient buy pH strips, okay? They have to check their urine, and the pH has to be 6.5 or higher. If it is lower, then they have to take more. So if you prescribe sodium bicarbonate, 650 milligrams 2 times a day, then you go to three times a day as tolerated. Now, obviously, when you're prescribing potassium, you have to be careful if someone has chronic kidney disease. Now, if that's not enough and uric acid is high in the blood, serum uric acid is high, it is reasonable to prescribe allopurinol, and the dose is 100 to 300 milligrams. But allopurinol is not our first-line treatment. First line is increased water intake and urine alkalinization for uric acid stones. And actually, some stones can dissolve that way. So it's very, very effective. Now, I didn't say anything about calcium phosphate stones. You see those in people with primary hyperparathyroidism and in patients with distal renal tubular acidosis. So if someone has calcium phosphate stones, they really need a workup to find out why they have it. They need to see a nephrologist, a kidney specialist for further workup. Okay, cystine stones. On the urinalysis, when we look at the urine sediment, we see those classic hexagons. Okay, so these are cystine crystals. Okay, you only see them in case of cystine stones. Those patients need really high water intake. So now we're talking 3 liters. Okay, and preferably they're going to get up in the middle of the night and maybe drink water. So maybe they have to get up at least once during the night. So they have to stay really hydrated. Urine alkalinization, the same way like we talked about with uric acid stones. And we have specific treatment for this type of stones with thiol-containing drugs. We have thiopronine. I think nowadays no one uses the penicillamine. I've never used it. It's very toxic, but I've used thiopronine. Now, lastly, we have Struvite stones. Now, Struvite stones is magnesium ammonium phosphate stones. Now, when you look at the urine sediment, you see these crystals which look like coffins. And those stones can be huge. So here you have the ruler, 7 centimeters. So these stones will cause complete blockage. They will occupy the whole renal pelvis and cause hydronephrosis. Now, they have to be treated surgically. Okay, so actually any stone that is big, say 8, 9, 1 centimeter, will, especially if it's like blocking the ureter, will have to be treated surgically. These stones definitely will have to be treated surgically, and you need complete surgical stone removal. Now, those stones happen because of urinary tract infection with urea splitting organisms. So you are going to use short or even long-term antimicrobial therapy. And contrary to everything we talked about here, you have to acidify the urine. So many use urease inhibitors like acetohydroxamic acid, AHA. I hope that this short video, was helpful. See you in the next video.